especially a fresh total knee, even an ACL or something like that, a lot of times because of the incision site, a lot of that scar tissue can bind down the patella and not let it slide and glide appropriately. So in addition to getting in and doing some of that cross-friction massage to the incision site to free that up to allow the patella to glide, a lot of times you really need to do some patellar moves, okay? Patient can be supine, they can be sitting, either way. And you sometimes can prop a little taller underneath here, but you don't want too much. You usually want the patient in full extension. If the patient doesn't have full extension, sometimes I'll put a small towel underneath there just so that they can relax when I do this. But you don't want them bent up in, 5, 10, 15 degrees of flexion because your patella doesn't move that way, okay? It won't glide or roll and slide. So if the patient straightens their knee, that patella has to roll and glide there, whereas if they flex their knee, it rolls down. If they extend their knee, it glides up, okay? So with extension, if they're lacking just those last end degrees of extension, if you've got this really bound down in the scar tissue here, sometimes if you just get in to mobilize the patella, that will get them the extra extension, okay? So don't ever look at the patella when they're lacking motion. If the joint's moving fine, if their soft tissue seems to be pretty flexible. Good to get in. You can work on this post-surgically. They have a whole bunch of edema. Just be careful with it, but you can usually work them pretty much, right from the start, okay? So the way I tend to do this is with the borders of my hands. I tend to go here. You can also do it with 2 thumbs. And a lot of times when you have a really swollen patella, it's going to be tough to find those borders. So just kind of sink into it and really make sure you're underneath that border, that you're not down here. Because I'm sure, I don't know if those of you have seen these fresh post-op and fresh patients, the patella is huge, okay? So you're kind of like, where are you in there, okay? So you just want to either get with the web space of the hands or the thumbs here, and you want to make sure that you're going in parallel, okay? Parallel to that tibia and femur, because you don't want to jam the joints, okay? So if they're not liking this, you can just be jamming. So make sure your glide is in parallel, okay? So this would be just a superior glide here to improve extension, okay? The opposite way, I can do an inferior glide to improve flexion, okay? Just coming straight down toward this foot. Yep, you can do 2 thumbs. You can do web space, just as long as I make sure I'm not going this way, kind of gliding perpendicular straight across, okay? So either way, whichever way you guys feel most comfortable doing it, any of those directions, okay? You can also do a little bit of lateral glide. Usually a lot of people don't need that. Most of us have the patella sitting laterally, but most people are going to need that medial glide where you're just grabbing here and coming in. A lot of people with patellofemoral pain, that type of thing, sometimes some of the lateral retinacular structures, the IT band gets bound down in here, and in addition to freeing up the soft tissue, you can get in there and mobilize it. You can also, sometimes our kneecap tends to be tilted a little laterally in general, so you can also get in on this medial border and just do a little bit of a tilt to it, okay? You don't have to know that for lab, so just FYI. I think the only 2 that are listed there, are they superior, inferior? This is medial, lateral, okay, yep, so those 4. Superior and inferior, you have to know what they improve, and then just medial and lateral as for mobility, okay? And then you can do some massage over here as well to that retinacular structures while you're doing that medial glide. Usually post-op patients, not as much. Work on your 4 directions, superior, inferior, medial, lateral.